Good evening and a warm welcome to all the dignitaries present here. I'm Srevshi from Clanet, serving as the allocated session assistant to ensure a seamless experience. Clanet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clanet serves as the digital partner for this event hosted by the Indian Society of Pediatric Neurosurgery, and the focus of today's session is Pediatric Neurooncology. So let's begin today's session, for which I would like to invite Dr. Suhas sir to take over. So please proceed with the talk.
Thank you, Tracy. And good evening, everybody. This is the virtual classroom of the Indian Society for Pediatric Neurosurgery. These classes are meant for residents and trainees as a part of the Pediatric Neurosurgery curriculum, and through which we bring the national faculties to cover the pediatric neurosurgical topics. Today, as a part of our sessions on pediatric neuro-oncology, we have a session on systemic therapies for primary CNS tumors. And we all find systemic therapies, understanding systemic therapies, a bit of daunting task and sometimes overwhelming to cover up our complete scheme of understanding of CNS tumors. So to cover the topics, I have my colleagues from Dr. Girish from Tata Memorial, Dr. Manas Kalra, and Dr. Vasudeva Bhat from Manipal. So Dr. Girish will take over, and beyond that, he will introduce in detail his colleagues to you.
Great. Thank you very much, Suhas, and good evening, everybody. So we are really very thankful for the Pediatric Neurosurgical Society to actually invite us to talk on this aspect, and we would be quite happy and to have a bilateral and a very interactive session here about systemic therapies, especially in pediatric neuro-oncology, where probably systemic therapies have made the most impact in neuro-oncology compared to adult cancers. I'm Girish. I'm a pediatric oncologist from Tata Memorial Hospital in Mumbai. And I have my colleagues, Dr. Vasudeva Bhat, who is also a pediatric oncologist, and he is from Manipal Academy of Higher Education from KMC Manipal, and he heads the pediatric oncology department there. And I also have Dr. Manas Kalra, who is a senior consultant at Gangaram Hospital and head of the pediatric oncology unit there as well. So I'll start off by giving an overview of where systemic therapies stand in pediatric neuro-oncology. And then Dr. Vasudeva Bhat will talk in detail about low-grade gliomas approach and cover the systemic therapies which are used in low-grade gliomas. And Dr. Manas Kalra will talk about approach to embryonal tumors, which will talk about he'll talk about the chemotherapy and the various regimes used in pediatric embryonal tumors. So between low-grade gliomas and embryonal tumors, we would cover most of the pediatric cancers, pediatric brain tumors, where systemic therapies are used. So I'll share my screen now and just start off with an introduction. So I think you can all see my screen.
Yes.
Yeah, so we'll talk about, just to put things in perspective, we will talk briefly about pediatric brain tumors. So pediatric brain tumors are the second most common cancer in children. So unlike in adults, we see a lot of our oncology work involves pediatric brain tumors, and there are very few specialized centers in the country where pediatric brain tumors are managed by a multidisciplinary team. So in India, we see about 22 children per million children would get pediatric brain tumors every year. And it's a very heterogeneous group. Obviously not one disease, it's multiple entities all put together. The critical component is that the morbidity and mortality of pediatric brain tumors is probably the highest among all pediatric cancers what we deal, much more than leukemias if you look at the percentage of mortality which occurs and the morbidity which occurs. So a lot of it is disease related, but we also have significant treatment related mortality and morbidity, and that's what's some of the aspects what we will discuss today. So it is very critical that we actually make a timely diagnosis and initiate appropriate multimodality therapy in a very optimized and a timely manner. So just to give you a brief overview, you all know that pediatric brain tumors can have varied presentations. It can just present with raised intracranial pressure, present with focal neurological deficits. Seizures or seizure disorder may be a presenting feature of a pediatric brain tumor, especially the low-grade ones. It can present just with endocrine dysfunction, growth and nutrition problems, especially tumors in the suprasellar hypothalamic areas, or it can just present with behavioral issues, hypothalamic tumors or tumors in the frontal lobe, etc. So it can have a combination of these constellation of symptoms, and it requires a high index of suspicion by the pediatrician to actually pick up a pediatric brain tumor. So the time lost between the first symptom to actually diagnosis of a pediatric brain tumor is substantial in most parts of the world, and that has a direct impact on the morbidity which has occurred because of the tumor itself. And as you know, most of the morbidity which occurs due to pediatric brain tumors at presentation, is especially the neurological damage, loss of vision, etc., is usually permanent and becomes a significant factor which impacts the quality of life, even if you cure the child with the tumor. The manifestations by site, all of you know that supratentorial tumors and posterior fossa tumors have got different manifestations, but many times you get a combination of those. And central tumors normally do not have raised intracranial pressure and they present with either visual or endocrine symptoms, etc. And these are all the various combinations which are there, and we will not go through that in detail, but this is just to tell that it has got a very protean presentation, and it is critical for us to keep in mind that pediatric brain tumors have a very wide spectrum of presentation. And these are the same with the brainstem tumors, which present more with cranial nerve palsies and rather than raised intracranial pressure. And then spinal cord tumors, which would, depending on the site of the cord, may present with from as subtle changes as back pain to actually loss of function, bowel, bladder, etc. Now, workup of the patient of a brain tumor is generally divided into three aspects. The first is the emergency management, and most of the children actually come to the neurosurgeon. So in the emergency management, the management of the raised intracranial pressure, which I'm sure all of you know well and has been discussed before too. They may present just with dyselectrolytemia, and that may need to be managed. Seizures, emergency management of seizures, etc. So the definitive treatment, although it is multimodality, many times start with the management of the emergency itself. So if a child comes with significant raised intracranial pressure, you may do something on a short-term basis to actually decrease the pressure, but you would also go in early with surgery wherever feasible to actually decrease the intracranial pressure, and at the same time be able to get tissue out, give a definitive therapy, which may be surgery in many cases, and at the same time provide tissue for pathological and molecular diagnosis, which would further determine what treatment has to be instituted after the surgery. Now, the definitive treatment is multimodality. I will come to what are the types of modalities used in pediatric brain tumors subsequently. But as you all know, commonly it's surgery, chemotherapy, and radiotherapy in that order in children. In adults, it is surgery and radiotherapy and much less of chemotherapy. It is also critical to remember all the supportive treatment which are involved in managing a brain tumor child. So nutrition becomes a significant issue if there is aspiratory weakness, bulbar weakness, or diencephalic syndrome, tumors which are occurring in the hypothalamic region. You might need to involve the physiotherapist and occupational therapy very early in the management. Speech and swallow therapy, endocrine issues where the endocrinologist may need to be involved too. Now, the distribution of pediatric brain tumors, gliomas are the most commonest, followed by embryonal tumors, and that is what we will focus today. And this is from the database, CE database in the US. But even if you look at India, this is one of the largest papers which were presented. Gliomas, astrocytomas, which is in the top row, as well as the medulloblastomas and PNATs, which are the embryonal tumors, are about 50% of the work what we do today. Now, there is a shift in the management of pediatric brain tumors. So one, there is a better understanding of tumor biology, which allows for molecular risk stratification to be done. And that has helped us to intensify therapy for poor risk cases and decrease therapy for good risk cases. And there's a completely a paradigm shift in the approach of how pediatric brain tumors are managed, in the sense that multidisciplinary team approach starts from day one, the brain tumor is actually diagnosed. And to add to that is the pathologist has become a very critical component in management of all brain tumors, especially in pediatrics. Now it is mandatory that you actually make a diagnosis on pathology based on the WHO 2021 classification, and that is what is called layered reporting. So it has incorporated molecular subtypes along with the histological grade into the diagnosis, and that helps us for not only prognostication, but also to direct the therapeutics. So the impact of knowing the molecular subtypes along with the histological grade has made a significant impact in how we actually manage pediatric brain tumors and what type of therapy we actually give subsequent to the diagnosis. So coming to multimodality therapy, so these are the common pediatric brain tumors, what we see. So if you look at the top row, medulloblastoma and embryonal tumors, all children require surgery, all children require chemotherapy, and pretty much everybody requires radiotherapy as well. So this only does not apply to the less than 3 years old, where the modality of the radiotherapy may be actually different. It may be more focal rather than craniospinal when required. Otherwise, most of the time, craniospinal irradiation is done in more than 3 years old only. If you come to low-grade gliomas, depending on the site, you may do surgery or not do a surgery. You might even do a radiological diagnosis. You may give chemotherapy or not give chemotherapy. You may give radiotherapy or not give radiotherapy. So it's a very, very individualized decision on when we give chemotherapy, radiotherapy, and do surgery in low-grade glioma. However, the newer change in systemic therapy is the advent of targeted therapy, which will be discussed in the subsequent talks as well. For high-grade glioma, surgery becomes critical. There is no role for chemotherapy in a pediatric high-grade glioma, the pediatric glioblastomas or the grade 3 astrocytomas, what you see. And radiotherapy is what is instituted to all of them. Ependymomas, surgery and radiotherapy are critical. Chemotherapy has very limited role in very select situations. Whereas you come to intracranial germ cell tumor, chemotherapy and radiotherapy are mandatory, and both of them in a combination actually give a very good outcome. And surgery is done only in a limited number of cases. So in an intracranial germ cell tumor, the diagnosis is most of the time made by radiology with a combination of blood tumor markers, and the need to do surgery upfront is very, very limited. So can we actually cure pediatric brain tumors with only one of the modalities? For example, can we cure low-grade glioma or get a good outcome with low-grade glioma with radiotherapy alone? Or can we cure a medulloblastoma with average risk with surgery and radiotherapy alone? Or can we cure intracranial germ cell tumor with radiotherapy alone? And the answer is yes. To a substantial number of it, you can actually do that. But the statement below the table is what I want to highlight on. By bringing in chemotherapy, you are actually using multimodality therapy to decrease long-term toxicity of radiation while maintaining efficacy. Remember, giving radiation to a child has significant late effects of therapy, and to decrease that, though it is a very good modality for improving, getting good outcomes, to decrease that, you would use a combination of this. And the timing of multimodality therapy becomes critical. Now, systemic therapies are of these three types. You would use chemotherapy, either conventional or high dose, targeted therapy, and immunotherapy. Now, the chemotherapy drugs, what we commonly use are very, very conventional. All of them are beyond a patent periods. All of them are fairly cheap to use. They're relatively inexpensive, but the supportive care required is intense because the side effects and toxicity of chemotherapy is pretty significant. And hence, it's recommended that pediatric brain tumors be jointly managed between the neurosurgeon, radiation oncologist, and the pediatric oncologist so that the chemotherapy can be given and appropriately supported as well. So these are all the drugs which are commonly used, and between these drugs, you are able to treat most of the pediatric brain tumors where systemic therapy is required. But the side effects are significant, and the significant side effects are these. You get blood counts dropping significantly, which leads to infections and febrile illnesses in the setting of neutropenia. Cisplatin and carboplatin can cause ototoxicity, especially when combined with radiotherapy. You can get kidney toxicity by both platinums and ifosfamide. Neuropathy due to vincristine is also quite common, and many times doses need to be changed. And having infertility, electrolyte imbalance, and a large number of late effects, which I'll come to in the next slide. So these are all the treatment-associated late effects of children who have been treated with cancer. This does not apply only to brain tumors. It applies to brain tumors and all the other extracranial tumors and malignancies treated in children as well. And as survival of childhood cancer has reached 70 to 80%, we are seeing a large cohort of patients who are actually having the significant late effects and continuing to need medical care as they grow into adulthood. So the late effects of therapy in brain tumors are all these. So growth gets affected, endocrine replacement is required lifelong, and many times is multiple endocrine deficiencies from thyroid to pituitary dysfunctions, neurocognition, especially after radiation, infertility, both due to chemotherapy and radiation, vascular events leading to multiple aneurysms in a child who grows into an adult due to radiation, second malignancies to both modalities of therapy. And we have, over a period of time, identified the children with brain tumors have both higher chance of metabolic syndrome, cardiac events, as well as significant psychosocial problems. Now, the graph on the right shows the top three curves, which are in red, green, and blue, are actually the grades of late effects seen in pediatric children who have been childhood cancer survivors. And the graph below that, which is in purple, is of their siblings. As you can see, even though they grow up in the same environment, childhood cancer survivors have a significant late effects and they grow into adulthood 15, 20, 30 years post-treatment, and which has also got a higher chance of mortality, as it's shown on the right side as well. Now, that is about systemic therapy. We also use high-dose chemotherapy, which is called non-myeloablative chemotherapy, for mainly high-risk medulloblastomas and infantile brain tumors, which Manas will cover. That is another modality of systemic therapy, which can be delivered only in specialized centers. We also use systemic treatment chemotherapy for radiosensitization, where we use carboplatin or vincristine for actually improving outcomes in high-risk medulloblastomas. And these are data from 2 studies which show there's a 50 to 60% outcome. But when we use chemotherapy for low-grade glioma, it has not been easy on the child at all. So it causes significant compromise on the childhood. Child misses school and there are significant school dropouts. Therapy schedules are keeps them frequently to the hospital. They miss normal childhood activities, significantly affects growth and development, and all this in low-grade glioma for a 50% improvement only. So the question is there an alternative to treat children, pediatric brain tumors better, especially in low-grade gliomas? And I'm sure Vasu will cover that more. So we have molecular subgroups, which has led us to develop numerous targeted therapies, which are listed here. And the outcomes are generally equivalent, but can targeted therapy become frontline in part of systemic therapy rather than chemotherapy? The answer is probably yes. Over a due course of time, it is significantly expensive, but it does offset the problems what we see with chemotherapy in terms of toxicity is much less, and they can actually attend school and parents don't need to relocate to the center or to the city where chemotherapy is delivered. So there are other situations where we use systemic therapies like mTOR inhibitors in tuberous sclerosis. We also use checkpoint inhibitors in high-grade glioma. This is a very recent development that 10% of high-grade glioma, especially in children, are driven by alteration in what is called replication repair machinery. And these alterations make these tumors very, very sensitive to checkpoint inhibitors. And we are able to maintain the disease under control in high-grade gliomas, especially in glioblastomas with who have got the replicate repair deficiency, and keep the disease under control for many years without doing radiotherapy. However, this is very much new data and emerging therapy, and this is one of the tumors which has been treated in Canada. As you can see, even after recurrence, the response was good. And the curves on the right show that the outcome when you give checkpoint inhibitors is very good in patients who are actually eligible. It requires a lot of molecular testing to be done, and we can discuss that later if anybody has a query on that. So the other options in systemic therapy, we have newer targeted therapies called NTRK inhibitors used for infantile hemispheric glioma. We use a lot of what is called epigenetic targets for Inostat, which are in early phase trials, but still not come into frontline therapies. Immunotherapies, CAR T cell therapy, you all have heard of it for leukemia. It is under trials for pediatric brain tumors and other tumors as well. NK cell, which is another type of immunotherapy, which is off the shelf and that is being trialed too. And one of the ones which have been tried in India in some centers is metronomic therapy, where you actually target the tumor microenvironment, but there are actually trials going on at the moment, including in our center, to see whether it actually improves survival in embryonal tumors. To summarize, pediatric brain tumors are a very heterogeneous group and management is complex, requires a specialized MDT. And the critical component is what I would like to stress again is timing of multimodality therapy. So once you've done the surgery or the surgery has been done, it is critical that very early you involve the radiation oncologist and the pediatric oncologist for deciding what is the best combination of multimodality therapy to use for the child so that you can optimize the outcome. Risk stratification is very, very critical. So imaging appropriately, getting the right pathology and molecular testing is critical. That is what helps us to decide what systemic therapy to use. And there are new therapeutic implications which are evolving as well. So I will stop here and then I will ask Dr. Vasudeva Bhat to actually talk on pediatric low-grade gliomas, pediatric gliomas. And then after that, Dr. Manas Kalra, and then we can take questions in the end. But you're all most welcome to put your questions on the chat and we will keep answering them as we go by. So Vasu, you want to share your screen?
Yes, I hope my screen is visible.
Yeah, just put it on slideshow now.
Yeah. So thank you, Dr. Girish. And I think Dr. Girish has set the tone and given the complete, you know, kind of overview of the pediatric brain tumors that we see. So I'll be talking about the pediatric gliomas. So the gliomas generally are the most commonest brain tumors that we see. Like I mentioned, like Dr. Girish mentioned, that brain tumors are the second most commonest tumors that is seen in the childhood. So just before that, what is basically a glioma? So all of you know that there are neurons and the supporting cells that are there are called the glial cells. So basically, there are 4 cells within the central nervous system, which includes the ependymal cells. So and they basically line the ventricles, and any tumors which arise from the ependymal cells are called the ependymomas. The oligodendrocytes, what you can see here is they basically help in the formation of myelin. So any tumors arising from these cells generally are called oligodendrocytes. Astrocytes form mainly the blood-brain barrier, and tumors arising from them are called astrocytomas. Microglia are basically phagocytes which are present within the CNS. So CNS tumors, again, it is very complicated if you see the latest classification, but if you make it simplified, it is classified into the glial tumors, embryonal tumors, choroid plexus tumors, the germ cell tumors, and craniopharyngioma and other tumors. I will be focusing on the glial one, mainly the astrocytic tumors, the low-grade glioma, and briefly about the high-grade gliomas. So what constitutes these low-grade and high-grade glioma? If you see, and you would have seen the reports, basically the grade 1 and the grade 2 are generally the low-grade gliomas, and grade 3, grade 4 are called the high-grade gliomas. What helps in the grading is basically the mitotic index, the cellular atypia, and pleomorphism, presence of microvascular proliferation and necrosis. So the more microvascular proliferation, more necrosis, it favors the grade 4 high-grade glioma. So this is the CNS, the 5th edition classification of CNS tumors, and in that, if you see, it is classified into pediatric type, diffuse low-grade gliomas, diffuse high-grade gliomas, circumscribed astrocytic gliomas, and so on. So the latest classification has basically incorporated this as well as the molecular rearrangements that are there. So, for example, there are entities where there is a MAP kinase pathway altered. So, if possible, always the molecular workup can be done for these tumors, and they can be classified as per the new WHO 2021. But most centers and most places, it is not we are not able to get the complete molecular profile or the methylation studies. So hence, still the CNS5, the 5th edition classification is followed. So when it comes to the low-grade gliomas, it is always, whether to give chemo, whether to, the surgeon always asks us, should we remove it, should we biopsy it? And the radiotherapists are always ready with a plan. So that's why I thought maybe we will put about 3 to 4 such case scenarios, which because there are a lot of trainees who have joined the session, it may probably help them. So when we talk about the low-grade gliomas, I think the approach is very important. Not all the tumors probably require a systemic chemotherapy, but the most important thing, what we see as pediatric oncologists and what is generally discussed in the multidisciplinary tumor boards is that whether these tumors are actually surgically accessible, can it be resected upfront? What is the site of tumor? For example, if it's a posterior fossa or it's a cerebellar astrocytoma, it's generally easier to operate compared to something that is present in the optic chiasma. Similarly, there are certain deep-seated tumors which are not possible to be biopsied or operated, and hence we rely upon clinical examination to look for any features of syndromic association and the radiological features. Again, we always consider as pediatric oncologists what is the age of the child and what late effects will this particular therapy lead to. So for example, when we consider radiating a 3 or a 4-year-old, we will always think about what possible late effects are there. And most of the treatment is based upon therapies which will prevent the late effects, because generally the outcomes of these tumors are excellent. Again, syndromic association is very important, because if you have a child with neurofibromatosis and you have an option of chemotherapy versus radiation, radiation increases the risk of second malignancy, and probably it is best to defer the radiation as much as possible. And again, as Dr. Girish had initially mentioned, the general condition is very important, and one needs to manage the initial part where there may be a hydrocephalus, there may be dyselectrolytemia, etc. So just 3-4, I think, case scenarios that we will go through for the low-grade gliomas, which will help to understand how we plan the treatment. So this is basically a 3-year-old child who had presented with some vision disturbances and had a syndromic association on examination, basically had some cafe spots. And this is the MRI. We can see that there is a lesion at the optic chiasma. So we all know that optic chiasma, just below that lies the pituitary, and the treatment, again, if at this age, if we radiate, so the late effects are much high. So our goal here probably is to get a visual assessment if possible. When there is a neurofibromatosis with a classical optic pathway glioma, generally a biopsy may not be required. And again, the option here would be probably chemotherapy itself. And our goal is mainly to keep it as a stable disease. We do not want this particular tumor to grow further, but this child requires frequent monitoring of vision as well as radiological evaluation. So here our goal has changed mainly because of the age and because of the presence of the syndrome, where we want to defer radiation for this particular child. Similarly, this is another child with a cerebellar low-grade glioma, 6 years old, non-syndromic. You can see the small lesion which has been, and here our goal would probably be resection itself. And if a complete resection is done, that itself is sufficient. You can manage, you can just observe this child after the resection itself, and you do not require any further therapy as well. This is a syndrome that is seen especially in children, where that is called the diencephalic syndrome. It is basically because of a hypothalamic glioma. And these children are usually diagnosed quite late, because the symptoms basically include headache, sometimes recurrent vomiting. There is increased feeding, and then followed by vomiting, many times diagnosed as a gastroesophageal reflux disease. What we can see is that there is a failure to thrive, but the stature is actually maintained. And these tumors are very difficult to biopsy because of the location. So in these scenarios, again, biopsy may be avoided, and one can go directly for systemic therapy, that is chemotherapy. And I will be talking about what chemotherapy, what is the duration, and what is the side effect profile. So the last example is, this is a tectal plate pediatric low-grade glioma in a 15-year-old non-syndromic. Here again, the goal probably will be excision itself, and followed by, it is difficult to get a complete excision, so there will be some tumor which is left behind. So many times we give adjuvant radiotherapy because of the location. So these were just 4 scenarios, and as you saw, the treatment differed for each of these patients. And when we talk about systemic therapy and what chemotherapy, there are various regimens that are available. So the commonest ones that are used are the vincristine along with carboplatin, or the vinblastine as a single agent. What is important to see is, what is the 5-year progression-free survival, and generally it varies from regimen to regimen, somewhere between 40 to 60%. And there are other regimens also which are used, like the TPCV regimen, the vincristine, carboplatin, temozolomide, the bevacizumab, and irinotecan regimen. So the important part is that it is not just one cycle. It needs to be given for a longer duration, sometimes for a duration of up to 18 months, generally up to about 12 months. So what it does is that, there is school absenteeism because these children require weekly chemotherapy injections. And definitely these injections come with a side effect profile, especially when Cristin and carboplatin are combined. Then chances of neutropenia, febrile neutropenia, and some children requiring admission for this is also there. Uh, Weekly venlafaxine is also used in some centers as the first regimen because it is easy to give, and there is a risk of neutropenia associated along with this as well, but it is also well tolerated. And we mentioned about the targeted therapy in the first talk, and most of the pediatric low-grade gliomas are driven through some of the other mutations. And this is very important to know because it has therapeutic implications. May not be currently now, but going ahead, these medicines may be available, and it may be easily available as well. So if you see, there is this pathway called the RAS-RAF-MEK-ERK pathway. So any NF1, that is neurofibromatosis 1, also acts through these pathways itself. There are the RAF here. There are two types of mutations which can be seen. So the BRAF V600E and the BRAF fusion. So based upon the type of the fusion or whether it is a BRAF V600E mutation, the treatment is different. So for the BRAF fusion, trametinib is what is used, and for the BRAF V600E, dabrafenib and trametinib is preferred. So what is the problem? Why these are again tablets which are available? What is the problem, and why we are not using probably for all the children is because of the cost that is involved. And if you see, if you have a child with a low-grade glioma with a BRAF fusion, again, before we start these targeted therapies, it is very important to define what is the mutation or what is the, what is the target, whether it's a BRAF fusion or whether it's a BRAF V600E mutation, because again, the medicines differ, and without having a biopsy and without having this report, it may not be right to start the treatment. So if we see a child who has a BRAF fusion and the drug of choice again is trametinib, if we see about for a 30 kg child, it comes to about 45,000 per month, and the duration is actually not known, but it is believed that at least 2 years needs to be given. So that is the cost that is involved with the treatment currently. And for a child with a BRAF V600E mutation, the drug of choice is dabrafenib, and recently FDA has approved a combination of dabrafenib and trametinib. So the cost comes to somewhere around 1 lakh per month. So if you use a combination, it's about 1.5 lakhs per month. So again, this needs to be continued for a long duration. So hence, it is not sufficient that we start it. We always have to ensure that it is continued, and at least for a duration of about 2 years. There are some papers which are talking about making these lesions resectable using the targeted therapy, then operate and then stop. But again, it is not known as of now. It is to continue for at least a duration of 2 years or probably more. So the cost remains one of the major constraints when it comes to using these targeted therapies in our country. So briefly, this is about the low-grade gliomas, and if you have any questions, because of lack of time, it's actually it is a vast topic, and each aspect of it, like the chemotherapy or the targeted therapy or the approach itself, is it's an hour long. But I've tried to shorten it and make it as an approach and a case based. But please feel free to add any questions in the chat box, or please raise your hands and you can ask. Briefly about the high-grade gliomas. So again, the pediatric high-grade gliomas are biologically distinct from the adult high-grade gliomas, and 50% of them actually have a mutation which is known as the H3K27M mutation, and the remaining So the H3-2K7 is generally the midline ones. The remaining ones, the hemispherical ones, have the H3G3 R/5 mutation. So there are also high-grade gliomas which are secondary to mismatch repair deficiencies, and Dr. Girish mentioned about these entities which responds to immunotherapy beautifully. And a newer entity called the infant high-grade gliomas, again, are biologically distinct group of tumors which occur generally less than a year. In children, when we say infants, especially in brain tumors, we usually consider them as less than 3 years. But these infant high-grade gliomas usually occur less than a year. They are usually supratentorial in location, and they have definite molecular targets like NTRK, which can be targeted. So it is recommended, especially for this group of patients, that the targets are identified, and if the targeted therapy is actually given to these children, they have shown good prognosis compared to the H3K27M mutations. So when we talk about the high-grade gliomas, again, maximal safe surgical resection with the aim at complete resection whenever possible gives the best outcomes. When it comes to older children, like not the infants, the older children, adjuvant radiotherapy to the tumor bed again offers best chance at cure, but eventually about 70 to 75% of the children will eventually recover. Use of oral temozolomide during radiotherapy and following that also has shown modest benefit, but again, this data mainly comes from adults. And in children, we do not know whether temozolomide actually works or not, but we adapt this from the adult studies. Again, like previously mentioned, the role of chemotherapy in high-grade gliomas is again quite complicated and may change over the next few years depending upon the molecular features. So based on this, I have a couple of cases where what we had seen, 3-year-old child with complex partial seizures, and the MR brain showed a left temporal lesion over here, underwent a resection, gross total resection. It is called anaplastic astrocytoma. And this child actually got focal radiotherapy along with concurrent temozolomide, followed by adjuvant chemotherapy with temozolomide. Again, here the benefit is uncertain, and it is basically extrapolated from adults itself. And this child actually is doing well for 4 years post-diagnosis. So this was a grade 3 high-grade glioma, anaplastic astrocytoma, which was managed by focal radiotherapy post-surgery and given temozolomide, but again, we do not know the benefit and is doing well. But there are, these type of tumors as well, 14-year-old female with a short history of headache and left-sided weakness. And there was a 3 into 3 centimeter thalamic lesion with a lot of edema surrounding it. It is a midline location, H3K27M mutant grade 4 glioblastoma. So this child had undergone surgery, but only a part of it could have been removed, got focal RT with temozolomide. Again, post radiotherapy, post this, there was a temporal transient improvement, but again, eventually these recur, and this we lost this child 12 months from the diagnosis. So this is a basic approach that I had put, and if there are any questions, please feel free, because like I mentioned, this is quite a vast topic to cover in about 20 minutes time. And if there is anything that you need to know more about, we can always discuss this at a later time.
Great. Thanks, Vasu. We can now go ahead and finish with Manas as well. He will talk on embryonal tumors, and then we'll take the questions. So there is a question there in the chat box, but we'll come back to it at the end. Manas, you can start your presentation on embryonal brain tumors approach in children.
So are my slides visible and I'm audible?
Yeah,
Yeah.
visible.
Okay.
Yeah.
So at the outset, I would like to thank Dr. Girish, Dr. Suhas for giving me this opportunity. I'll be talking about embryonal brain tumors in children. So we know that embryonal brain tumors constitute around 15 to 20% of the pediatric brain tumor cohort. And in fact, medulloblastoma is one of the most important tumors that we treat routinely because there is an immense role of chemotherapy in these patients. So embryonal tumors in the current classification are classified into medulloblastoma, and they have put the molecular bit into it, where medulloblastoma can be classified into medulloblastoma Wnt activated, medulloblastoma sonic hedgehog activated, and medulloblastoma, which is non-Wnt, non-sonic hedgehog. And the sonic hedgehog ones have either TP53 mutation or they are wild type. And the group 3, group 4 get clubbed into the non-Wnt, non-SHH medulloblastomas. You can also talk about medulloblastomas in the form of histologically defined, and I'll come to that in a bit. And the other CNS embryonal tumors, which are actually rare, difficult to diagnose, difficult to manage, but are now increasingly becoming important because a lot of them were in fact clubbed into either CNS PNET or were wrongly diagnosed as medulloblastomas. But now, because of the availability of molecular testing, sophisticated IHCs, they are now divided into a various categories. And the important ones are ATRTs, ETMRs, which are the embryonal tumor with multi-layered rosettes, CNS neuroblastomas, FOXR2 activated, and CNS tumors with BCOR internal tandem duplication. And these other CNS embryonal tumors are also now getting their due share of importance, and they were largely undiagnosed in the past. So first I'll talk about the medulloblastoma group, which is the second most common CNS tumors in children. They are most common malignant CNS tumors, generally located in the posterior fossa. They are all WHO grade 4. This is an aggressive embryonal neoplasm, and it is more common in males, just a slight bit male preponderance. Now, they can be associated with certain syndromes, like in this particular child, where this sonic hedgehog activated medulloblastoma was found to be associated because this patient actually had a Gorlin syndrome. And we could only realize it later when the mother complained of a dental cyst, and we evaluated the child and found that the child had a underlying Gorlin syndrome, which was predisposing the child to have a medulloblastoma. Similar way, you can have medulloblastoma in patients with Turcot syndrome. They can have these colonic polyposis, and this may be associated with medulloblastoma, and also children with Lee-Fraumeni may be associated with medulloblastoma. So while evaluating these posterior fossa tumors, it is very important that we subject these children to a good MRI with contrast. The imaging will reveal a large heterogeneous mass in the posterior fossa, and often there will be some contrast enhancement. The initial approach to these children has to be a maximal safe resection of the tumor. A gross total resection is ideal, but not at a cost of significant morbidity to the child. So approximately 30% of these kids will have metastasis at the start. So ideally, a spine MRI should be done before surgery, but if it is not done, we generally wait for 14 days post-op to evaluate the patient with the spine MRI with contrast. This is clubbed with the MRI of the local area to see the residual disease, along with the lumbar puncture, which is sent for CSF cytology. And this also is generally done after 2 weeks of the surgery for all the debris and the other post-op changes to kind of resolve. And that evaluation is a must for every patient of medulloblastoma. After you have done the basic evaluation and you have sent the tumor specimen for analysis, the pathologist will generally tell you whether it is a classic medulloblastoma, a desmoplastic tumor, MBEN or a desmoplastic nodular, or a large cell anaplastic histology of the tumor, which is generally associated with a poor outcome. The desmoplastic and the MBEN is generally associated with a better outcome. Now, this is further classified based on the molecular typing, as I had already alluded to, and I'll come to that again in detail in a bit. So the typical histology is that of a classic medulloblastoma that you can see in this image, but you may have a very nodular kind of a tumor located laterally on your imaging, which is can be a desmoplastic nodular, generally has a good outcome. Or you may have a very highly nodular tumor like this on imaging, which is generally a MBEN, again, associated with a very good outcome. The large cell anaplastic is an aggressive form of medulloblastoma and is generally not seen in infants as the histology. So once you have done the basic scan, you have done the surgery, you have done the histology, you generally risk stratify these patients. So medulloblastoma can be risk stratified. This is the Chang's classification. It just uses the basic kind of parameters to classify medulloblastoma, and can be done at any center. So you look at the age of the patient. Generally, all infants, which is, in brain tumors is generally defined as less than 3 years, are high-risk patients. Large cell anaplastic is high. If you have a CSF or a spine metastasis, that is considered high. If you have a residual disease more than 1.5 centimeter square, this is also considered high-risk medulloblastoma, and the other gets classified into a standard risk medulloblastoma. Now, as alluded to by Dr. Girish and by Dr. Vasudeva, the molecular typing is taking a huge importance in classifying pediatric brain tumors, and medulloblastoma is also a prototype tumor where molecular biology has shed a huge amount of light. So, and medulloblastoma is classified into a Wnt associated, a sonic hedgehog, group 3, group 4, which gets clubbed into non-SHH, non-Wnt pathway tumors. Wnt is associated with the best prognosis, and that is why therapy de-escalation is being tried for these patients. So when we talk about Wnt, generally Wnt is not seen in infants. Infantile tumors are either sonic hedgehog or group 3 tumors, whereas pediatric tumors, non-infantile, can be any of the 4 categories. If you have a sonic hedgehog mutated tumor, and it is associated with TP53, it is generally a poor prognosis. But infants don't have P53 very often. So infants with SHH, non-metastatic, is generally a good disease. Now, group 3, if it is associated with MYC amplification or is associated with metastatic disease, it generally carries a poor prognosis. Group 4 has generally a better prognosis than group 3, and the Wnt carries the best outcome of all the 4 medulloblastoma types. And India has shown the way of how immunohistochemistry can be used as a surrogate to molecular typing, which is still very expensive in our country. It costs around 40 to 50,000 to molecularly type these medulloblastoma, and these immunohistochemistry markers act as a surrogate to kind of predict what type of medulloblastoma we are dealing with. Once we talk about the infantile medulloblastomas, SHH has got the best outcome as compared to group 3, which is inferior. And generally, by histology, desmoplastic tumors carry a better outcome as compared to the large cell anaplastic histology in medulloblastoma. But this infantile medulloblastoma is particularly challenging because generally they have a aggressive biology. They are difficult to resect. We don't want to give RT to them to avoid long-term sequelae. And that is why these children are, diagnosed late and treated with great amount of difficulty. So we try to do a maximal safe resection for these children. We want to avoid craniospinal because of the late effects. We generally give them aggressive chemotherapy. We don't want it to be too toxic because children can have toxic deaths as well. And at the same time, we have to preserve neurocognitive outcomes. And this is, trust me, not very easy. So the approaches for infantile medulloblastoma have been either usage of intraventricular chemotherapy, where, through an Omaya, we inject the chemotherapy. And we have done it for around 5-6 patients at our hospital in Gangaram. Or we use, this is clubbed with intensive chemotherapy for these patients. And generally, desmoplastic have got a very good outcome. The other approach for infantile medulloblastomas is using a high-dose chemotherapy. So you give them an intensive induction followed by intensive chemotherapy, which is generally followed by an autologous stem cell rescue. And this is, again, aggressive therapy for these patients, and you can get a reasonably good outcome. But therapy de-escalation for infantile medulloblastoma generally doesn't work very well. So the two main groups, which are the SHH and group 3, we know that group 3 generally has a poor outcome. SHH non-metastatic do well, but really speaking, to get good outcomes, we either need a high-dose chemotherapy or an intraventricular methotrexate-based strategy, and we want to avoid or delay radiation for these patients to get good outcomes. When we talk of non-infantile medulloblastomas, so again, emphasizing that these are children more than 3 years, radiation becomes a very important part of managing these patients. The standard risk medulloblastomas can be managed with a CSI of 23.4 gray and a total boost to the posterior fossa of around 54, whereas the high risk medullos generally require full dose craniospinal of 36 gray, and we give them a posterior fossa boost again to the same tune of 54. It is very important and that these patients are referred for radiotherapy early. A multidisciplinary team discussion is done for every medullo, and we get the pediatric oncology involved very early in the course, because some of these high risk, we like to give them concomitant carboplatin along with the radiation. And Dr. Girish had shown the paper which actually improves the outcome of these, some of the metastatic medulloblastomas, and we follow that at our center as well. Now, whether it is standard risk or high risk, after the radiation, we give them a 4-week break, and this is followed by a maintenance chemotherapy, which is absolutely essential for these patients to prevent recurrence and to improve the outcomes. Now, the various strategies to manage these patients is either usage of high-dose chemotherapy, which is, the St. Jude's approach of managing these patients. But what we conventionally use, and this is, the protocol that I'm sharing is what we use at Gangaram Hospital, is generally using 3 drugs, which is inspired by the Packer's regimen, where we use cisplatin, cyclophosphamide, and vincristine. We have a little difference for our standard risk and the high-risk patients. And with this chemotherapy, most of the patients with medulloblastoma can be cured. And you can see that the WINT does very well. The group 3 is kind of inferior as compared to the others. And again, those who are metastatic disease, those who have a residual disease, generally do poorly. So medulloblastoma more than 3 years, if you're completely resected, non-metastatic, you generally do well. WINT are the good players. SHH, if you have metastasis, P53, bad histology, they do poorly. Group 3, Group 4, with MECAN amplification or metastatic disease, do poorly. Generally, Group 4 is better than Group 3. You need higher dose of radiation for those with metastatic disease. We use carboplatin concomitant for these patients, and chemotherapy does as good as autologous transplant, but all these patients need a long-term follow-up. Now, coming to the other spectrum of embryonal tumors, an important chunk is ATRTs. And, we are kind of scared of these tumors because they come in young children. They are very aggressive. They are WHO grade 4. And they have this biallelic inactivation of SMARC B1 or SMARC A4. And these tumors are particularly, very aggressive, and they come back very quickly. We have the kidney counterpart as well, and some of them can have those, especially those who have genetic disorders. They come with synchronous tumors at various sites. They have a typical histology, and I won't go into the details for that. And they have these rhabdoid-like cells, but the typical thing is the loss of INI1 nuclear staining in the tumor cells, which is uniform, and there is the retention of this staining in the endothelial cells and lymphocytes. The treatment is again very aggressive, intensive multimodality therapy. Now, these are young children. We want to avoid radiation, but it's kind of very challenging to do that. And there is a definite role for high-dose chemotherapy and transplant for these patients. And I know that a lot of oncology residents are also attending this seminar, and we have some encouraging outcomes now for these patients. Like, I'm just highlighting this TOG algorithm, which uses intensive induction followed by which contains methotrexate, and early consideration for RT for a little bit older children, avoidance of RT for very young children, and then follow them up with high-dose chemotherapy. And that has, if we compare it with our historical patients, has shown some improvement and some encouragement to the outcomes of these children with ATRT. Again, it is very important that as a multidisciplinary team, we involve our geneticists, because they may have a rhabdoid tumor predisposition syndrome, which can happen in the next child as well. And some work is being done for targeted therapy in these patients. The next category is the ETMR, which has got this C19MC alteration, and they have this typical IHC, which is LIN28. Now, these tumors, again, were being just managed like PNETs of the brain. They are aggressive tumors. They may have leptomeningeal dissemination. And, it's kind of hard to diagnose them just with the neuroimaging. So biopsy, IHC, and FISH studies, FISH for documenting the C19MC alteration, and IHC can be very helpful to diagnose these patients, which otherwise may have or may not sometimes have the multi-layered ependymoblastic pseudorosettes, which are very typical of this condition. Now, management, again, this is a very aggressive disease. You need to do a maximal safe resection, and then you have to give them subsequent chemotherapy, including high-dose chemotherapy, stem cell transplant, and there is a strong consideration of radiation for these patients. But again, these young babies, we want to avoid radiation for the fear of long-term side effects. And this is one of the papers where, this PHIT trial, which actually showed that if you don't have brainstem involvement and you have a ETMR, you have a non-metastatic disease and you have a ETMR, if you use a carboplatin etoposide induction followed by high-dose chemotherapy, you may have some survivors in this category of aggressive tumors. And again, that is encouraging. Just coming towards the end, we have two more categories. One is the CNS neuroblastoma. So we never knew of this entity. And again, they were also classified into the PNET category. But now we have, this typical histopathological markers like the SOX10 and the RD55, and we have the molecular studies which can pick up these FOX2 rearrangements. And it is important to pick these children. They come somewhere around at 5 years of age. 10 to 15% non-medulloblastoma embryonal tumors comprise of this condition. And it is important because, these patients have good outcome. So they would otherwise look like a neuroblastoma, like histology markers will be like neuroblastoma. They will be supratentorial in location. They will be large tumors. But this molecular testing helps you to make this diagnosis. And this is the PNET patients. And see, now when they have retrospectively gone and evaluated these patients, the best outcomes, this black line is actually the neuroblastoma ones. So those who received CSI, those who received intensive chemotherapy, after the CSI were the ones who actually did well. They were treated by the HIT-SKK protocol, but these patients were later identified to be neuroblastoma, and they've shown an outcome of 60 to 80%, which is really encouraging. And just the last category is this BCOR internal tandem duplication. Again, you need this molecular testing to diagnose this. IHC of BCOR can also help you pick these conditions. This is a very small percentage of the medulloblastoma, non-medulloblastoma CNS embryonal tumors. Generally, around 3 to 4 years, they would present. They are high-grade tumors. Again, you need a maximal safe resection, radiation, high-dose chemotherapy. But again, this case-based reviews has shown some encouraging survival for these patients as well. So just to summarize, you need expert pathology and IHC to diagnose these embryonal brain tumors accurately. Increasingly, molecular studies have helped us to classify these tumors better. A complete surgical resection is what we aim for, but we are happy with the maximal safe resection because we don't want to give them long-term morbidity. A prompt referral is needed for radiation and pediatric oncology teams. Radiotherapy for non-infant tumors is often needed, but for infant tumors, we want to avoid it. Chemotherapy and high-dose chemotherapy plays a vital role for some of these tumors. Outcome of many embryonal tumors is encouraging, and multidisciplinary team is the key to optimize the outcomes. Thank you.
Thanks, Manas, for giving an overview on a very large topic in 15 to 20 minutes. So what we'll do, we'll take questions. We'll start off with the chat questions which are there. The first one is for Vasu. It says, is low-grade gliomas in infantile age group biologically different from those in older children?
Yeah, so if we see in the low grade versus the high grade, the low grade generally are driven through the RAS-RAF pathway itself. But when it comes to the high grade gliomas, these are distinct. They are completely different biologically. Again, like I mentioned, in the infantile age group, there is a different entity Beyond that, based on location, midline versus hemispheric, again, the targets are different. So if you look at the low-grade gliomas per se, it is predominantly under one pathway itself, along with associated some other pathways like FGFR and etc. But by and large, it is driven through one single pathway.
So just to add to that, for the low-grade gliomas in the very young, the question of targeted therapy becomes very complicated. So if we can't give radiation and if surgery is not fully resectable many times, because a lot of them are in the diencephalon, the tumors, what we see, or in the optic pathway. And in that situation, chemotherapy is the main option which is left for us to use. And the reason we can't use targeted therapy, one other than the cost, is that these are only tablets available in India. So liquid formulations are far more expensive and not yet come to India. And you cannot crush this because they get inactivated in the gastric juice. So for that reason, you have to give chemotherapy majority of the time if you are not able to operate it and observe. So the second question is, again, Vasu, what is the role of MGMT expression in high-grade glioma, and is it necessary to do in all patients? So in adults, we always do MGMT. So the question is, in pediatrics, should we do MGMT or is there any role?
So, so again, in adults, the MGMT methylation has shown, if it's methylated, it's shown better outcomes with temozolomide in terms of median survival, which is about 21 to 22 months compared to 14 to 15 months otherwise. So in adults it does, but in children, most of the times MGMT is unmethylated. So that is the reason why we do not feel that temozolomide, what we use, may work in these patients. So in children, generally, it is not recommended to get it done. And again, role of temozolomide is very questionable, but many centers still give it based upon the adult data.
So just to tell you, the high-grade gliomas in children, two things what you must remember is that one is that a proportion of them will have mismatch repair deficiency syndrome underlying. And the high-grade glioma, whenever you get in a child, please ask the pathologist to do immunohistochemistry for mismatch repair, and they will be able to do and tell you whether it is there or not there. And the same thing when you get an hemispheric glioma, especially in the very young, less than 3 years old, you can also do NTRK. Again, the drug is not available, but it's a matter of time. In the next 2 years, 3 years, the drug will be available in India. That has taken away the prognosis from very poor prognosis to made it to a pretty good prognosis if you have NTRK positive in an infantile high-grade glioma, which is in the hemisphere. So for that reason, these are two rays of hope in high-grade gliomas in children. In children, high-grade gliomas are rare, but in these two, there's a ray of hope that you can use these alternate therapies to actually get a good outcome. So the third question is for Manas. If a child with standard risk medulloblastoma goes on to receive full dose CSI, craniospinal irradiation, so which is 36 gray, as recommended for a high-risk medulloblastoma, then does it mean adjuvant chemotherapy can be omitted? So as in for average risk, we would give a lower dose, reduced dose craniospinal irradiation plus chemotherapy. But in case you ended up giving a full dose, can we avoid adjuvant chemotherapy?
It's an interesting question. I've never thought about it, what we should do, but I think the role of chemotherapy is important. And, we should by all means avoid giving the full dose CSI to a child who has a standard risk medulloblastoma. So I would first make a full attempt to avoid giving. If you have already given, I don't think we can take away radiation completely from take away chemotherapy completely from these patients. I don't know, Girish, what do you think about it?
So, yeah, there'll be, I mean, it's obviously a rare scenario, but in case somebody has given a full dose craniospinal irradiation, many of the times that has been done because the molecular testing and other testings are not available. And for that reason, it has been done. But in case you're able to test it and even later find out after the radiation that it is actually a good risk or a average risk medulloblastoma, where you would have given lesser dose of radiation and chemotherapy to get the same outcome, but actually to decrease the late effects of radiation. You would use a combination of chemotherapy and radiation. But if that happens, that you're in error or given it as a over precaution that you are given a higher dose of radiation, then chemotherapy can be avoided if you are fully sure that this is actually a average risk medulloblastoma. If you get a 23, 24-year-old average risk medulloblastoma, even today we would do only radiation.
Sure. Yes. Correct.
Spinal radiation, and we would not give chemotherapy at all. So it is a similar thing. The only difference is 23, 24-year-old neurocognitive impact is far less of radiation. In a
Yeah.
child, it's much more. That's why you use a combination of two modalities to decrease late effects.
Decrease the late effects. Yes.
So the next question is again for Manas. Can we reduce the craniospinal dose to 23.4 in group 3 medulloblastoma even after complete resection and it is non-metastatic?
So, really speaking, for us, doing molecular studies for every patient is challenging. So, our treatment is basically decided on your histology, resectability, the amount of residual tumor, metastasis or not metastasis, and the age of the patient. And for most of these patients, if all these criteria are met with, we give them 23.4. Now, we don't know if some of them may be group 3, and we choose to treat them only with 23.4 based on our Chang's risk stratification. Even if we know that it is group 3, but it is completely resected, NMIC not amplified, I would probably go with 23.4.
Yeah.
If there is no metastasis.
Yeah, that's absolutely right. Non-metastatic, completely excised, a classic histology. It shouldn't be a large cell anaplastic histology. And you get a group 3 NMIC, not a MIC, not amplified. You can avoid full dose radiation and give a low dose radiation. Anybody else wants to raise hands and ask questions? Please feel free to do so.
I had two questions for the low-grade glioma and Dr. Manas. And tell me, Dr. Bhat, you said diencephalic syndrome. It's a tough condition, isn't it? A baby is a very has a very poor genetic condition. So how do you play with your standard chemotherapy drugs?
Yeah, so it's quite challenging because on one hand, nutrition, you need to take care of that, plus you need to give chemotherapy. But what has worked for us is chemo itself. But again, it's not very easy to manage, and many of the times we have had dyselectrolytic leukemias occurring throughout, or at least in the initial phase of therapy. But I think there were few children who have responded. I mean, of course, these are quite rare, and one would see only about a single or two cases every year. But chemo is the way to go probably for them. And we have used usually single agent vinblastine or a combination of vincristine and carboplatin in these patients. But yes, they need to stay close to the center whenever we are giving. There is a risk of neutropenia. There is a risk of refeeding syndrome also that occurs. They are on Riles tube, and they require more monitoring compared to a regular patient. But we cannot irradiate these patients also because of the age. So the options that remain is only few. And again, biopsying these lesions are extremely difficult, and we may not need to biopsy these lesions generally because radiological and clinical features do support that it is a hypothalamic glioma itself. So if maybe Dr. Girish wants to add, because with the limited, I think, few patients that we have seen, that this has been the challenge. But for a couple of them, it went fairly well. The initial part was quite difficult, but then slowly after the weight gained and general condition was much better, there was an improvement in the symptoms and child was better.
So I think the diencephalic syndrome needs admission and needs to be done as an inpatient with monitoring by the nutritionist, the good nursing care, as well as by the medical team. Electrolyte, endocrine evaluations, all that to be done early, and electrolyte evaluations frequently if required. But no biopsy or anything is required generally because most of them are low to intermediate kind of grade gliomas, and we would generally not biopsy it and go ahead with chemotherapy. And the first sign of recovery is actually weight gain. The first sign of recovery is not radiological. The first sign of recovery is actually weight gain.
Any instance where you would refuse treatment?
In
diencephalic with low-grade glioma.
If we will refuse treatment, or the family, you mean?
Of course, the family is counseled, isn't it?
Yeah. So we wouldn't normally refuse treatment at all. We would encourage them to go for treatment because still the out cure rate is still, as in at least the long-term survival is still 60 to 70% in those. Not as good as a complete low-grade gliomas where you would say 85, 90% with multimodality therapy. Here it is still 60 to 70%.
I had a question for Manas too. Infantile medulloblastoma. Is there any role for radiation at any point of time?
So generally we try to avoid radiation, but definitely for recurrent disease, you could give radiation because the outcome of neurocognitive sequelae is going to be disastrous for these children. So, and we have other options available. So generally what we do is we give them either chemotherapy through Omaya along with intensive chemotherapy, systemic therapy, or we do high dose chemotherapy for these patients. We want to avoid radiation for these children, but if they have recurrent disease, progressive disease, radiation may be an option just to kind of save the life of the child.
So there's another question about, is bone marrow required in medulloblastoma? That's one question in every case or only in a specific case?
So we don't perform medulloblastoma marrows for every medulloblastoma if the CBC and everything is well, and if the children are not very, like cachectic and sick with the disease and having bone pains or something like that. We generally don't do it. I'm not sure what you guys do at your center.
Yeah, no, I agree. I don't think anybody does routinely any bone marrow testing for medulloblastoma. It's only if clinically there is a suspicion that there's an extracranial metastasis, which occasionally can occur.
Yeah.
Common in pineoblastoma. So pineoblastomas have more extracranial metastasis. So otherwise we would not do. Then there's a question about radiological diagnosis of glioma in a child with NF1. What's the role of biopsy? And conventional chemo versus targeted therapy, which is better to start with? I guess this is for NF1 child.
So generally when you have a child with NF1, in the sense that you have Kaplan spots, you have a family history of neurofibromatosis, and you have this feature of optic pathway glioma, then you generally need not biopsy this. Most of the times we end up giving conventional chemotherapy itself. The reason being is that you have to avoid radiotherapy in these patients. So conventional chemotherapy is generally what is preferred. When it comes to targeted therapy, because these are again going through the same pathway, the potentially yes, targetable, but still one prefers to use conventional chemotherapy in this subset of population itself. And generally single agent vinblastine is what is usually preferred in this, and the children, there is data from Sick Kids Canada stating the benefit of using single agent vinblastine in these patients.
Yeah.
One last question from Amrit or running out of time.
Yeah, I think we'll take this last question. Experience using sodium disulfide with cisplatin in medulloblastoma to avoid ototoxicity. Manas?
So we have used it for 2 children with medulloblastoma and 1 child with hepatoblastoma. Again, procuring the drug is a little tricky. It comes with the cyanide poisoning kit. We have to get it from Gujarat, and we have used it for just these 3 patients. And I think the literature says to use only for standard risk medulloblastoma and not for high risk medulloblastoma, because you don't want the efficacy of the drugs to go down, and which may actually increase the chance of relapse. But I think the jury is still out there, and we need to know more about this drug and its safety and efficacy for our patients. So just very limited experience we have.
Great, thanks. So
can I just ask one question? I wanted to ask this to Dr. Girish, because he mentioned in his initial few slides about the role of immune checkpoint inhibitors for high-grade glioma. So just for all of us, that when to screen these patients for mismatch repair defect, and which high-grade glioma should be screened, so that how do we know which one would benefit from immune checkpoint inhibitor? So what's your policy?
So there is, all glioblastomas we would screen who come, and obviously if a glioblastoma is a second malignancy following a leukemia, then 100% we should screen. In that setting, it's definitely a mismatch repair. Otherwise, all glioblastomas we screen because it can be primary presenting for that condition. Anybody who has got cafe spots and doesn't have NF1, a child, history of colon cancer or any colon issues which are there, which are the Lynch syndrome and others, are the situation where we would actually screen. It's the immunohistochemistry is easy to do on the tumor. So that's why I think most people are doing. I mean, you send it to most neuro-oncology centers. Most people in a child with low-grade glioma, high-grade glioma, would get a glioblastoma, would test for it generally. So there are 4 IHC markers to use, and they're pretty straightforward to do it.
Yeah.
So do you do the germline testing or something like that, or just the IHC based?
IHC will give you a diagnosis that this is a mismatch repair. To confirm it, you can do a germline because then you can test with other family members as well.
So just consanguinity is also a common thing. There is a history of consanguineous marriage and sometimes history of a sibling death secondary to, say, a mediastinal mass. We had one such child, elder sibling died of mediastinal mass. So all these probably raise the antenna to probably, inform the pathologist to check. And then if you have a medical genetics person, then of course you can always get the germline testing also. It's important to test the parents also in that situation in case this comes positive, because it has a impact on them as well, and we need to put them on screening.
Girish, should we close?
No, Swas, actually, Swas, this is Dr. Naveen.
Yeah, Naveen. Hi, Naveen. Tell me.
Yeah, hi. Dr. Girish, I have a question. Hello.
Yeah, go ahead.
Yeah, sorry. It is not about the pediatric brain tumor, but I recently operated upon a 9-year-old child who has come with back pain and became plegic with bladder bowel involvement within a day. And it came out as an aggressive vertebral hemangioma. So we did emergency pedicle screw fixation and relieved the cord. But now the hemangioma is still there. It's very aggressive with a lot of dilated blood vessels. So is it the definitive treatment should be, we can wait for some time because the child is still recovering, or should we go in with direct removal of the tumor, or we have some radioembolization or radiation? Any comments on that?
So is the tumor within the cord or it's outside?
It's outside the cord. It's compressing circumferentially.
Circumferentially. So if it is not supplying the cord, that blood vessel, then definitely embolization can be tried. And that's something what we would do, and we have done it in other tumors as well. If surgically you debulked it and child is recovering, then there is no urgency to do. We can wait. Definitely we can wait.
Because the family is very, and our endovascular surgeon is saying that if we embolize, it's going to recur again. So if you go for surgery, then only we will embolize.
So that is a strategy which we have done many times as well. If you're going for surgery, you embolize it 24 to 36 hours prior to actually make the surgery easier. But if there is not one feeder vessel, and if it is like multiple vessels feeding into the hemangioma, then embolization won't help. They are right. So that may not help at all. So depending on what the anatomy of the vasculature is, on that basis, only we can decide whether embolization will help, or embolization followed by surgery, or just surgery alone. Other option is if it is what type of hemangioma we have to see. If it is an hemangioma like a cavernous hemangioma or something like that, which is causing it, then you do have an option of using systemic therapies, which would be a drug like propranolol to start with if it's a small child. Usually they are the 2 and 3-year-olds where they respond. Drugs like everolimus, which can be used as well. So those drugs are possible to use.
So we can wait for at least 3 months. He's recovering, and then we can.
We can definitely wait. We can definitely wait.
Perfect. Yeah, and I think thank you, Dr. Girish, Dr. Vasudeva, and Dr. Manas. I think it was a very good talk, and I think we really got few important points and take-home messages from you. Thank you.
Yeah, I think Girish, Dr. Manas, and Dr. Vasudeva, you have clarified many issues of such a daunting, and I think residents and all the residents who have participated will get a headway towards their thinking. Anyway, thank you very much from NSPN. For all the residents, these classes are held every last Sunday of every month. You should be joining according to your convenience, of course. And thank you. And these topics will be available at the YouTube, so you can always go back to sessions because these are extremely heavy sessions. So you might be wanting to listen to it again. Thank you all for joining this session, and again, thanks to my co-teachers, Dr. Girish, Dr. Manas, and Dr. Bhat. Thank you very much, and good night.
Okay. Bye.
Thank you, sir. Thank you so much, everyone, for giving us the opportunity to host the session. And we hope to have you again very soon on our platform. Thank you. Good night.
Yeah, good night. Thank you.